Well, good afternoon, everybody, and thank you for joining us today. We are thrilled to have such a broad and engaged, diverse group joining us for today's webinar. All corners of the healthcare ecosystem seem to be covered: drug manufacturers, hospitals, health centers, associations, consultants, third-party administrators, and everybody who is essential to the strength and the integrity of the 340B program. And so whether you're tuning in from a policy perspective or an operational one, and you have a focus on patient care, your presence here reflects an open-mindedness to solving some of the challenges in healthcare, which I think we can all agree has been a little daunting for the last 5 years, especially in 340B. Times of uncertainty for sure in the 340B space, a lot of concerns around sharing data, duplicate discount, challenges that arise from different stakeholders using different tools, in some cases, some not using tools at all. The result's been gridlock in 340B, and that gridlock doesn't just affect the stakeholders, but can ultimately impact what I consider, and I think we consider the ultimate stakeholder, the patient. And in 340B, in the case of 340B, it's the most vulnerable in our nation. At RxParadigm, our innovation-driven leadership approached this challenge with conviction and the idea that there was a better way forward. And that conviction was built on technology and collaboration. We saw the issue not only as critical, but solvable. And that belief led to the development of Tungsten+PLUS, which is our neutral clearinghouse solution that we'll talk about today. It has a very flexible work design, and it helps deliver clarity and balance to what seems to be an imbalanced world. And the clearinghouse is live, and we are super excited to share that information. And today we've got with us some of the early adopters. So we have speaking today Marty Carty, who's the Director of Government Affairs at the Oregon Primary Care Association. Dave Christian, who is the Pharmacy Director at Central Virginia Health Services. David also comes to us via our relationship at RxParadigm with the Virginia Primary Care Association. And speaking of primary care associations, we've got Elena Nicolella. She is the President and CEO of the Rhode Island Health Center Association. And then Bryant Anderson, CEO of PrairieStar Health Center in Kansas. And they'll all share their experiences. And then finally, our kind of, I would call him our cleanup hitter, but I think he's fifth, is Yogesh Arora. He's our Chief Technology Officer here at RxParadigm, and he will talk about the role of Tungsten+, really at the intersection of 340B and maximum fair price. As you know, those provisions are related to the Inflation Reduction Act, which is going to be implemented in 2026. So we're looking forward to a great discussion, and we hope this sparks even more collaboration, because it was, we like to say at RxParadigm, to all the parties, cooperation and collaboration is not capitulation. So it's going to take everybody's cooperation to solve this problem. Just a couple of housekeeping notes. All your mics will be on mute. As questions come to mind, you can add them into the chat. Sophie Tanganu, our Chief of Staff, will be monitoring the questions, and she'll help me lead the Q&A when we get there. And any questions we do not answer in the Q&A, we will answer it and then post online or send them around. And so let's get started. So the first question we get, and I'll address the clearinghouse at a high level for those of you who don't know anything about us or our company. Like, one of the questions we get a lot is, hey, I understand how a clearinghouse model works in other parts of healthcare, but can you share how it'll work in 340B? So this is just a high level overview of that. And you can see here, we have covered the solution Tungsten+. It's in between the parties, covered entities on one side, manufacturers on the other. And we're neutral, right? So neutral validation is what we provide to the claims. Those are claims that covered entities will gather and direct to the clearinghouse through your 340B processors. So those are the qualified claims that come from your TPAs, or if you're running an in-house pharmacy and do not have a TPA, whatever your qualification mechanism is, you'll drive those to the clearinghouse. The clearinghouse will take in rebate information from the manufacturers, and we'll look to match and show if a 340B is a claim is 340B or it's not 340B. It's very much that simple, even though the technology behind it is complex. The other piece that the clearinghouse does and works on as well is MFP, which Yogesh will talk about. a little bit later in the hour. And so it works. We covered the CE side. Let's talk about the manufacturer side. So again, manufacturers receive rebate invoices on a quarterly basis from the associated payers on the right. They come into the manufacturer's world, and the manufacturer's job is to determine, hey, is this 340B or not? Do I pay the rebate, whether it's a state rebate or a commercial rebate, or is the claim 340B? And we'll talk a little bit about why the data feeding into those sources tends to be incomplete. But they will take it, feed it into the clearinghouse. Again, the clearinghouse will do its matching, and then we'll help determine whether a 340B is claim is 340B or not, and the manufacturer, should they pay or not pay the rebate. So quickly on why we think then we know that the clearinghouse is the right long and midterm approach. We know that 340B modifiers have been wholly ineffective since they've been in the ecosystem. Less than 50% of the in-house pharmacies appropriately apply a modifier, so less than 50% of the time. And in-house pharmacies tend to have a little more control. We know that less than 1% of the time the modifier is applied at the contract pharmacies, and most of the major chains will not apply it. So what we have bad data flowing through the system, and so the PBMs, Medicaid, Medicare, any of the payers get a claim, and they don't know if it's 340B or not, and there's a lot of guessing that has to happen. So we know that inaccuracy in that data will never get solved in its current format. The restrictions, contract pharmacy restrictions, have been pushed back a little bit in that a lot of the states are having 340B legislation introduced and passed. So we feel like the shelf life of restrictions is limited. The credit and rebate model, has been shelved by the current administration seemingly. I don't think it's the end of the conversation for sure, but for now it seems like it's been put off to the side. I think we know that if that model is implemented, it would really change 340B compared to how it operationalizes now. And health centers and health systems will have to pay a lot of dollars up front to buy drugs. Again, that's just a fundamental change. We also see the clearinghouse have some ability to talk about managed care and carve-in. We also know that covered entities and manufacturers, because of the back and forth over the number of years, there's not a lot of trust in the system, but covered entities can trust that our clearinghouse has role-based access in drug manufacturers, because it's the second biggest question we get is what kind of access the other side will have, air quotes, that it's just on a claim-by-claim basis. It's a 340B claim or it's not a 340B claim, and if something is not a 340B claim, there's a reason code. So covered entities can be sure that their data is not being shared in an inappropriate manner. And the last question we get about the clearinghouse often is, how secure is it? It is high trust certified, and we're proud of that because it is the highest standard in privacy and security. With that, I'll introduce Marty Carty. Again, Marty is the Governmental Affairs Director at the Oregon Primary Care Association. And so, Marty, why don't you take it away?
Great. Carlo, you can hear me?
I can.
Great. Hi, good afternoon, and thanks for having me today. As Carlo said, I'm Marty Carty, the Director of Government Affairs at the Oregon Primary Care Association, or OPCA. I think for my comments today, I want to, just head back. Let's see. There we go. Yep. No, the slide before, Carlo, if you would, please. Okay. The introduction slide. Just a little context for who we are and who our members are. About 470,000 unique lives got cared in FQHC in 2023, serving Oregonians at just over 270 care location sites. And then here, almost 5 million prescriptions annually. So we have 33 health centers statewide and hope to bring all of them on board with the clearinghouse. All right, next slide. Okay. I have to go back about 2 years and say we've been fighting contract pharmacy restrictions on one front, as just every state has. We are a state that still carves Medicaid into managed care and captures those savings. And we've also been fighting on the PBM front around PBM reform over the last few years to include banning a claims modifier or identifier. And so I think we've been thinking about the clearinghouse as a strategy for solving the disruption that's been taking place over the last 5 years related to contract pharmacy, but also as a tool to solve just an administrative burden that our health centers have identified. And I'll talk about that first. So I'm sure many of you are familiar with a claims identifier or modifier. In our state, we don't, our health authority or our Medicaid agency doesn't use that identifier or modifier to identify Medicaid claims. We use a clearinghouse model that's a third-party vendor to ensure no duplicate discounts happen in Medicaid. What we don't have a good solution for are the duplicate payment avoidance or that rebate situation that Carlo described up front in all the other payer channels. And what I've heard from our pharmacy directors, what I understand from our contract pharmacy partners is that compliance with the program is difficult. Adding a claims modifier or identifier is difficult. And we have pharmacies, particularly in rural parts of our state, that are small, independent pharmacies that don't want to work with us just because of the compliance component, the tracking of the 340B program. And so we signed or really started to explore with RxParadigm. That was a real catalyst for us. I think the icing on top of the cake is, if there's an opportunity here to meet manufacturers where they are and start to avoid some of these contract pharmacy issues that are, restrictions in our state, we're also really excited about that as an opportunity and to just show goodwill and I think move the needle. I'm not suggesting, and Carl will be the first to tell you, I've argued with everybody until I'm blue in the face that, it's not our problem to solve. And yet, if somebody doesn't put their first foot forward, I don't think we get anywhere. Another thing we've been talking about is that I'm just trying to be forward thinking. All of the legislation on Capitol Hill that, whether it's bipartisan or not, includes a clearinghouse nationally. And so we think that getting out in front of any clearinghouse mandate that does eventually come from Congress around reforming the program also makes a lot of sense. So I think, for us, this clearinghouse model makes a lot of sense. We're just a month into a contract with RxParadigm on behalf of Oregon's 33 health centers. And, I think we're really excited about the opportunities that means for us around transparency, partnership with payers, partnership with manufacturers, and partnership with PBMs. Look, everybody's got an agenda in the 340B program. We want to make sure affordable drugs get to patients. Health centers can maintain stability in the healthcare delivery system. And so I think, we're doing our part to make sure that the program operates as it was intended. And, just one of the bullets here that I think really resonates for me is on the far right column, the second bullet down. At the end of the day, I think everyone on this call, if you work for, represent an FQHC, we're all committed to the compliance. We're all committed to program integrity. And I think we talk about it a lot. We talk about how we reinvest in patients, how we reinvest in programs, how we expand care. And all that stuff is happening, and I know it's true. But what we don't, at least in Oregon here, we just didn't have a good way to demonstrate that outside of Medicaid. And so I think the clearinghouse for us is that next step to demonstrate that compliance and proper stewardship of the program. So with that, thanks, Carlo.
And Marty, thank you. I appreciate it. And again, Oregon is always on everybody's radar because you guys have such unique ways that you handle Medicaid. So thank you again for sharing from the left coast. We'll bounce to the right coast, and I will hand it off to Dave Christian. Dave is the pharmacy director for Central Virginia Health Services. David.
Hey, thanks, Carla. First of all, I want to thank you for allowing us to be here today as I represent Central Virginia as well as the PCA. Just a little bit about us, Central Virginia Health Services. We are the oldest health center in Virginia, established over 50 years ago now. And over the past 15 years, 340B has become increasingly important to us operationally to be able to maintain our practice sites and even expand over the last 4 or 5 years. We currently have 22 locations, which cover about 20% geographically of Virginia. So we're very spread out. The last 5 locations that we opened up were done so with 340B revenue to allow us to get into those locations that needed our assistance. But the 330 grant funds were not there to help facilitate those openings. So what we do know is that as 340B goes, so does our ability to offer our assistance in those underprovided areas in Virginia. And so just to go back a little bit, Carlo and I were talking back in Phoenix at the 340B Grantee Conference about 340B in general, like we do most of the time when we get together. Sometimes you have to talk to those folks that are in the space because your family doesn't want to talk to you about it anymore. And so during that time, it was interesting. We had a bill, a 340B protection bill, a contract pharmacy bill that had passed both the House of Delegates and the Senate in Virginia in a bipartisan manner. I think we only had 5 votes against it in both houses. It was on the governor's desk, and he had questions about the bill. During this time, we finally got the notice that the governor had vetoed our bill. And so as Carlo and I were breaking down, what did that mean for us as a covered entity and 340B in Virginia as a whole? I was really just waxing on about, we've got to do something, because if we continue to wait on others to do something, we may be caught in a tidal wave of lost revenue, which would adversely affect Central Virginia, but also all the other health centers and grantees, covered entities, including hospitals in Virginia. And so we started talking about RxParadigm's offering of Tungsten+, and how could we work together to truly have a neutral clearinghouse that really didn't have a stake in anybody's camp, not the manufacturers, not the covered entities, but one that just said, hey, here's the data that we have. And from this data, these are 340B eligible, these are not. These may be a duplicate discount, so we need to look at them with a more stringent eye to make sure that we're not double dipping. And so we've always thought, as the health centers, we work tirelessly on being good stewards of the 340B program here in Virginia. And so that's really what started this whole process. And from the governor's veto, 2 things that he mentioned while he was vetoing our bill that really rang true to me that we needed to be able to solve as a grantee. And the first one is that he said that there's federal legislation being worked on for 340B. And my concern with that is that we've been working on legislation for over 4 years now for 340B, and probably further back than that if you look at even back to the omnibus bill years ago in the early teens. And so I didn't have any confidence at that time that we were going to get a bill that was going to fix this, the obvious issue going on around revolving around 340B in any time that was going to be helpful to us. And so if there's not something out there that's going to be fixed, if there wasn't going to be this white knight to ride in and fix it all, then we needed to start working on a solution. And so that's where Tungsten+ came in. And the other thing that he mentioned was that about the program is he wanted transparency. And I was like, well, that's something we can agree on, because the PCA here in Virginia, certainly Central Virginia ourselves, have always said that we don't mind being transparent. As a federally qualified health center, we're used to giving everybody our data. we get audited by everyone. So offering information on this program was not a concern for us. And we just wanted to make sure that everyone else knew that we were also being good stewards. But there are some challenges and that Carlo brought up earlier with the 340B program. And we discovered these ourselves because trying to be good stewards, we do our internal audits. We also have an external audit done. And during our internal audits, we'll find out where, even though we're placing the correct sub-clarification code on one of our in-house claims, it may not be transmitting. And so we discovered this on a routine audit one time that we ended up having to go back and fix all of these claims. And fortunately enough, we were able to do so. But because we ran into this situation a few years ago, we now audit every Medicaid MCO plan. And actually, I'll go a little further. We audit every prescription that comes back with a zero copay to confirm that it's not Medicaid, or if it is Medicaid, that we're submitting the correct sub-clarification code to identify to the state, hey, look, we took the 340B discount, don't go after the rebate. And so, again, being that we always want to be a good steward, we also want to be on the forefront of any planning to the solution of the 340B program. Our fear is, as a covered entity and having limited resources, is that if we're not part of the solution, trying to discover the solution, then we will have to adopt whatever someone else dictates as the solution. And then at that point, we'll have to try to find a way to be able to meet the standards that the program has. And so by working with Carlo and his team, what that's allowed us to do is say, here are some areas that we've identified that may be challenging for us to be able to send this type of data. How do we get this data to you in a way that does not cause a problem for us, in that we've got to go in and manually upload documents and other type of data streams. And so partnering with 340B has really helped with that. And at the end of the day, we do want to show the lawmakers that we do want to be good stewards. We promote transparency. We don't feel like we have anything to hide. And if there is something that we have done incorrectly, we want to know before it becomes an issue, as opposed to trying to chase it down after the fact. And so we fortunately for us in Virginia, we are allowed to carve in Medicaid managed care in our in-house pharmacies. And that's one of the reasons why we dispense so many of those prescriptions, is that we're able to do so in-house. Whereas if we're going through a contract pharmacy, we have to carve them out. And so that's really what drew us together. And I truly believe that the benefit of having a clearinghouse that is truly neutral will help us solve this problem, so that we can then spend some of our time that we've been just dumping into 340B and trying to figure this out, to go back to what we do best, which is serve our patients. And that's all I have, Carlo.
Well, thank you, David. That's great. That's great insight. Again, Virginia, every state's different, right? And so everybody has a different catalyst for why they would join the clearinghouse. But I appreciate that. And that is true. David and I we were talking at the conference. He leaned over to me and he said, tell me a little bit more about that clearinghouse. So that is exactly how it evolved, but for sure. So, well, thanks again. And next up is Elena Nicolella, and I'm pronouncing her name incorrectly, and I live in her state, so that's awful on my part. But Elena is the president and CEO of the Rhode Island Health Center Association, and again, a proud member. I am a proud member of her state, so I will turn it over to Elena.
Thank you, Carlo, and good afternoon, I guess, for most people. Good morning for some. Thanks very much for giving me the opportunity to talk a little bit about Rhode Island's experience and why we're participating in RxParadigm. So you can see that we are the primary care association in Rhode Island, and the 8 community health centers serve 210,000 Rhode Islanders, and that's about 1 in 5 Rhode Islanders. So a lot of us depend on the health centers for our care. We can go to the next slide. We have some similar themes to the previous speakers. I guess I'll talk a little bit about why we became interested in a neutral clearinghouse. It was really started by the risk of some draft regulations that the state Medicaid agency issued that were, they weren't an explicit carve out of Medicaid managed care, because we currently enjoy being able to access 340B and Medicaid managed care. But the rule essentially eliminated the ability for the health centers, to access the revenue from 340B. So that got the Primary Care Association and our health center members, and I recognize we have some representatives from Rhode Island in the audience. So very happy that you could make today's webinar. But that got us thinking, how do we show the state, our legislators, that we as a community are committed to transparency and accountability, to really neutralize this notion of their desire to carve out the Medicaid managed care option for us. So we did start to talk to Carlo and others at RxParadigm, and I'll just say another piece about working as a primary care association has been helpful, because to some degree it streamlined the ability of Rhode Island's community health centers to participate. So as in any state, the health centers are all a little bit different, all in different places, but pursuing this effort from the Primary Care Association lens allowed people to talk about the benefits and to think about how this would impact and how it would be implemented at each health center. So we've had a contract with RxParadigm for, I guess, about 2 months, and the health centers in Rhode Island are in the process of coming on board. So I'll just close out by saying we recognize that this is early in the process, but as the previous speaker said, we sort of felt like somebody's got to start doing this and show the value of the tool. So we might as well be on board. And it's a great reflection of the health center, again, health center's commitment to transparency and accountability. So thank you.
Yeah. Thanks, Elena. Now, last but certainly not least, we have Bryant Anderson. He's CEO of PrairieStar Health Center in Kansas. So we will cover the center of the country. Bryant's going to have the responsibility for speaking to everybody in between the coasts. Bryant was one of the early adopters of the clearinghouse and really saw the value after a handful of phone calls and a lot of questioning about our motives. He asked us a lot of tough questions, but he was one of the first health centers to join the clearinghouse kind of individually outside of the relationships that we build with primary care associations. He was also very instrumental in getting the legislation passed in Kansas for the contract pharmacy protection laws, and I will hand it over to Bryant.
Thank you, Carlo. Just tell a little funny story. You know, we all have our voicemail on our phones. They fill up, and there was this voicemail in there from this guy named Carlo, and it was a really busy time, and I finally picked that voicemail up and decided to listen to the whole message, and I gave him a call, and I am glad that I did. We had a great call. I think I said, I've got maybe 15 minutes, and so we can set something else up at another time. And Carlo, I think that call went on for probably an hour and 15 minutes, hour and 20 minutes, that first call.
Plus or minus.
Yeah. And then we set up a formal presentation, and I just have to say that when I saw that, it just, the light bulb went off. So, some of the things that the other speakers have said, some of it I may repeat a little bit, and I apologize for that. That's going last. Maybe I get to strengthen the argument a little bit, but this is definitely a solution that I'm extremely excited about. You might say here in Kansas, I had the opportunity to kind of vet it and let our local PCA know that this is something that we really should take a hard look at. We signed up right away because, as I said, the first time I spoke to Carlo, the state of affairs here in Kansas were a little bit unique in that we had both of our United States senators, Senators Jerry Moran and Senators Marshall. They were both involved in the legislative efforts at the federal level to protect the 340B program. So you might say Kansas was more involved than most in trying to find a solution to the disruption that occurred to the program starting back in the fall of 2020. For my part, as Carlos said, I was involved in discussions at both the federal and state level. Particularly at the state level, I was heavily involved in the discussions and legislation on that. And like many, at the time when I came across Carlo, I'd reached a state of extreme frustration with how chaotic the program had become. It seemed like every day we received a letter in the mail containing more bad news. At the time, there were some 20 states working on legislation. You know, the 340B legislation at the federal level continued to stall out. And of course, the lawsuits seemed like were piling up. So personally, I felt there had to be a better way forward because no one was happy, not the patients, not the covered entities, not contract pharmacies, not drug manufacturers. And then Carlos showed me the neutral clearinghouse concept, and I immediately saw the potential. It's not an exaggeration to say within seconds of him showing me that diagram that showed how that worked, which he essentially kind of showed you that here in his presentation. I immediately just saw that as the solution, and frankly, I saw it as the path forward. So here's just a few ways of how I see it as the path forward. I'd like to share with you just kind of my opinion of how I see it. I personally think it brings back the trust factor. Pharmaceutical manufacturers have made it very clear they believe duplicate discounts are a problem and have essentially mandated a one-sided data transparency solution that will never be embraced by covered entities due to a lack of trust. And, you know, to be fair, I don't believe pharma trusts covered entities either. And therein lies the beauty of the RxParadigm's neutral clearinghouse. It brings back the trust. And that's something that I saw right away. I thought, man, you know, this is a collaborative effort. This is a way that, you know, we can all share our data in that neutral clearinghouse and bring back that trust. So, you know, to me, using a third-party neutral clearinghouse ensures that everyone's data is protected. It's simple. It's a simple, common sense solution to restoring trust. So to me, that was something that I just saw right away. And then the next thing, the neutral clearinghouse removes uncertainty and restores the integrity. And, you know, a couple of the speakers kind of, you know, reference this. You know, it's important to understand that in most instances of Cs, we don't have any knowledge of whether duplicate discounts are occurring. I mean, we know they're occurring, but we don't see them. We don't know when they're happening. And that's because, you know, there's this wall. So we don't know, are MCOs taking rebates that they shouldn't be taking? We don't, you know, are PBMs consistently and accurately applying modifiers? We don't necessarily know that. So Cs simply don't know because there's that wall between us and the rest of the process. But what we do know is the duplicate discounts are occurring and that Cs are being penalized for the uncertainty that exists beyond that wall. So because the neutral clearinghouse has access to everyone's data and can reconcile that data, the uncertainty is removed and the integrity of the 340B program can be restored. So this should bring us all great comfort. The next one, I like to tell kind of a story of 1929 and the Great Depression, but you know, the neutral clearinghouse is the accountability solution. And I believe the gentleman from Virginia mentioned this, that, you know, if we don't provide the solution, then somebody else is going to, and that someone else is going to be the government. And we don't want that. So, you know, if we don't provide the solution to solving the chaos in the 340B program, the government will. And I assure you, we don't want it. So let me give you an example of what I mean. Following the stock market crash in 1929 and the subsequent Great Depression, you may remember that policymakers recognized that inconsistent and sometimes misleading financial reporting practices contributed to financial turmoil, which is code word for regulation is coming. Now, realizing this, the American Institute of Accountants and other professional groups recognized it'd be better if the private sector, not the government, provided the solution, and the SEC signed off on that. And so today we have something called the Generally Accepted Accounting Principles, and it's a self-regulating process. And that's what I would like to see us do. I've been to DC, I've sat with Senators Marshall, I've sat with Senator Moran, I've seen the legislation. The current legislation, if I recall, is approximately 51 pages long. That's the Sustained 340B Act. And that's a lot of pages of legislation, legislative language to solve a simple problem. None of us are going to be happy if the government provides the solution. It will create more administrative burden. It's going to come at a cost to the American taxpayer, and it's going to add more complexity. I can promise you that. So I believe we already have the solution in the RxParadigm's neutral clearinghouse solution, Tungsten. It'll decrease the administrative burden. It won't cost taxpayers anything, and it's simple. So finally, I would say the neutral clearinghouse ensures transparency. And this was alluded to earlier as well. For those of you who aren't familiar with the federally qualified health centers, or FQHCs, community health centers are one of the most data-driven and transparent healthcare models that exist. The neutral clearinghouse concept will allow us to ensure transparency by removing the data wall between CEs, MCOs, PBMs, and manufacturers, so that we can confidently know that we are doing our part to prevent duplicate discounts. And I think we all want to do that. So as one of the top performing health centers in the country, PrairieStar prides itself in providing high quality, transparent care to our patients. So providing our data to the neutral clearinghouse for us just makes sense. And I think it does for all of us. So as a side note, we even intend to include the RxParadigm solution in our 340B policies to further validate to HRSA in the event that we're audited, that we are being fully transparent. So simply to conclude, I can't speak highly enough of this solution. I believe that the neutral clearinghouse concept can restore trust between all the players and integrity to the program, remove the uncertainty, and ensure accountability and transparency.
Thank you, Bryant. And thank you for returning my call too, by the way. I appreciate that.
You're welcome.
Thank you.
I'm glad I did.
Thank you. Well, and again, thanks to Bryant for the Kansas view of the situation, and thank to all the speakers because I think they all provided a unique approach, and that's one of the things that we talk about a lot of times when people ask us, hey, we've got the macro issues of manufacturer restriction, but every state has a different reason, and a lot of health centers have a different reason and systems, hospitals. Ryan White's of why they would use the system as well. It's got some really unique, as Bryant mentioned, kind of continuous audit functionality, which we love as well. So just the last piece before I hand it over to Yogesh Aurora, our CTO, you can connect with me here. You can learn a little bit more about our company at the website or on LinkedIn. We'll be at the following events over the next couple of months. So if you see us and want to sit down and have a drink, a coffee, or a meal, we'd love to sit down and have a conversation or any kind of conversation. So again, and we encourage people to join the revolution we are creating. Anyway, so I will turn it over now to Yogesh to talk about the emerging challenge of MFP. Yogesh.
Thanks, Carlo. We can move to the next slide. So MFP, maximum fair price, as part of the IRA, it gave the government, Medicare, the right to negotiate price directly with the manufacturers, and started with the Part D drugs. And the way it works now is that a Part D claim will get adjudicated at the MFP price for those 10 selected drugs which have been selected for 2026, and the patient co-payments and everything is based on that. Pharmacies are reimbursed at the MFP price, and the MFP number of drugs right now in the January 1st, 2026 is going to be 10. And 15 additional drugs have been announced for which the negotiations are going on for 2027. And the plan is to move to 100 both Part D and Part D drugs by 2029. Pharmacies are reimbursed based on the MFP price, and CEs have right to claim lower of the MFP or 340B price as per the legislation. And so now, what problems can MFP create in the 340B? The way the legislation is written, a CE is allowed to claim either the MFP or 340B, and 340B can only be claimed if it's lower than MFP. And in the 2026 drugs which have been selected, some of them have MFP above 340B and some of them have MFP below 340B price. Pharmacies get paid the MFP, because that's how the claim goes through, because you are not able to put that modifier on the claim. And now when the claim reaches the PBM, they're going to adjudicate at MFP, and 340B part needs to happen behind the scene. And if you know what it is, it creates an issue between the 340B and MFP reimbursement calculation at the pharmacy and the CE and the TPA side. Uh, Definitely, because now you're getting lower of MFP or 340B impacts the revenue for the covered entities. And the last what we have heard, and it has come out in the new executive order, is the new administration wants to expedite the process and include more and more drugs into the negotiation. Next slide, Carla. Thank you. So what do we do in the clearinghouse? How do we help solve that problem? So the way it works is, if you look into this yellow circles, these are basically what CMS has proposed will happen. A dispensing entity, which is a pharmacy, will receive a prescription which goes through adjudication through a switch, and the plan sponsor is going to adjudicate the claim at MFP, sends a response back to the pharmacy. Pharmacy is going to dispense the prescription, and the plan sponsor is responsible for giving all the claim level data to CMS DDPS, which in turn gives the MFP drug data to claim data to MTF, which is a new module created by CMS. This is responsible for receiving all the claims, validating all the claims, and then once it has validated the claims, it passes on those claims to manufacturer. And what you see on our side is that black circle, where we receive the MFP claims in that on behalf of manufacturer in the clearinghouse model, and we can identify that claim whether it's being a 340B or not. And the piece you see below that is a configuration piece. As I mentioned, that it's up to covered entity what they want to claim. If the price is lower than the 340B, if MFP is higher and the 340B is lower, it will be up to the CE to decide which price they want to take on what kind of claims. So we allow the CEs to configure that for what pharmacies they want to take the MFP price for that NDC and what price do they want to take the 340B price. And as part of the clearinghouse, we also cross-check the MFP claims to see if a 340B claim has been done against it. If it is, then manufacturer, as per the CMS regulation, manufacturer can withhold giving the discount to the pharmacy for that claim, the MFP discount. And the last piece of that algorithm, 340B identification, is the algorithm. So the way the CMS is giving the data to the manufacturer, it has included the prescriber ID and the pharmacy ID into the claim for the purpose that manufacturer can use that to identify the potential 340B claims and work to ensure that there are no duplicates. So we have basically that algorithm which will help manufacturers in that case and to identify the 340B claims. We do definitely on the blue circles, what you see is what the data we get from the TPAs and CEs for the 340B claims. And what we do when we receive the 340B claims, we identify the MFP claims just to make sure there are no duplicates. Again, like there are claims which cannot be used, should not be 340B because the MFP is better for them. So the CE can roll back those claims. So we provide services to CE as well as manufacturer leveraging the clearinghouse. We can go to the next slide. And These are similar. I just said on the picture here is what we have written down here. For covered entities, we identify the MFP claims. We support the exclusions from the 340B discounts in the case covered entity says, okay, this MFP drugs, I do not want to take 340B. We help them. We make sure that if any of your claim comes which have been mistakenly taken as 340B, we identify, we notify, so CEs can roll it back. For the CE, we provide different kind of reportings to make sure that they can reconcile between their MFP and 340B claims at the pharmacy side. And on the manufacturer side, we have clearing house ensuring that manufacturer does not double pay 340B and MFP on the same claim. And we do that using various mechanisms. And we also help to keep track of the payments, accumulate those payments, and let the manufacturer decide when the payment is due, because there's a 14-day period within once the manufacturer receives the claim for the manufacturer to make that payment. And the last but not least is we help manufacturer integrate with the MTF help desk to dispute any 340B claims or any other reversal kind of scenarios. Thank you.
Thank you, Yogesh. It is complex for sure. I think as everybody knows, the IRO is well intentioned, but has created some complexities, and but we are here to help. So thank you again for the details on the coming challenges in 2026. I guess we can head to the questions now. Sophie, do you want to start to see what we have that came in for the Q&A?
Sure. So we have some questions in the chat as well as in the Q&A section. So I'll start with the chat, and whatever questions we're unable to answer because we run out of time, we'll send out a document after the webinar with answers to all of your questions. So looking through the chat, when you say duplicate discount, are you referring to HRSA's definition?
So I would say that it's seemingly the HRSA definition is upfront and very closely tied to Medicaid, which we get this question a lot. So it's a good question. A lot of times your TPAs should be addressing that duplicate discount and really blocking those bins and PCNs so that there's not a duplicate discount in Medicaid. I think what we're more addressing, and I think Bryant talked about this, and I have been corrected by Mr. Marty Carty for one time saying duplicate discount on the back end related to PBM, because that's really a duplicate payment. And that's how we look at it, is that, and that happens outside, and I think one of the speakers referenced this, kind of happens outside the view of the covered entity, meaning if a claim from one of the contract pharmacies got to a PBM that wasn't accurately identified as 340B, when the PBM gets that claim, they just look at it as a regular claim. They don't necessarily look at it as a 340B claim. So they send it to the manufacturer for their rebate, for their commercial rebate, and that's where we call it double payment versus duplicate discount. So I think both are correct, but it's a good question on clarification for sure.
Okay. What is the cost and who pays for the clearinghouse?
Yeah, another really solid question. So just for reference, in all the models that have been put out in DC for whether it's a Sustain Act or any of the 340B Acts, the clearinghouse model that they all reference, everybody pays. So we have a similar model to that. Health centers and hospitals will pay to use the clearinghouse. We think it is a nominal fee comparatively to the value. I can talk about pricing very directly with anybody who wants to talk about it, but in our model, everybody who accesses the clearinghouse pays. Covered entities, manufacturers, PBMs, anyone who needs access to clean data will pay to use it and get it.
Okay. What will be the impact of the administration's proposed transition of 340B from HRSA to CMS?
I'm not sure I have the ability to peer around the corner and answer that one. Marty, do you have, I know you're very politically tied in, or Elena, do you have any sense on that from your perspective at the state level? Marty, anything from that perspective? Because I don't know if I can answer that one. I don't know if it will be a shift. I think Robert, I'll just give you Carlo's personal opinion that Robert Kennedy seems to, his last name is Kennedy, and the Kennedys helped start some of the movement in community health years ago. So I think that's a net positive for health centers. I don't know if that would flow out to any other covered entity types. I don't have an answer for that, but Marty, do you have any sense?
I would also, whoever has the answer to this, also should give me the winning lottery numbers.
Elena, do you have the winning lottery numbers or any sense on this one?
I don't, I think it's a little bit concerning. Just maybe the focus will change, but no, I wish I did, but I don't know.
Yeah, that's it.
Okay.
Any additional questions, Sophie?
Does this have buy-in from manufacturers currently requiring data submission through ESP?
Yeah, it's a good question. I think that we see we've got about 7 or 8 manufacturers working in the clearinghouse now that I would say are not ESP manufacturers that have identified they have duplicate payment challenges, but they don't work with ESP. So we're working with that group now. We continue to have conversations. Matter of fact, our CEO and COO were at a very large manufacturer today sharing the clearinghouse model. We continue to have conversations with them. A lot of them are looking to do some kind of pilot projects with us. Ultimately, we believe that if the neutral clearinghouse becomes the standard or the generally accepted accounting principles, as Bryant shared, that the need for additional tools would in fact go away, but that's up to the other tools, what they decide to do. But we are working towards that goal now. I think it was Marty, or someone said, hey, someone has to take the first step. So we feel like we're moving down the right path, and we are encouraging and in conversations with many manufacturers to take that step as well. So,
right.
Carlos, sorry, Sophie, do you mind if I jump in?
Of course, go ahead.
Yes. This is our COO, Tim Nealon, who heads up the manufacturer strategy. So, Tim, thank you.
Yeah, good answer, Carl. I thought I'd just add to what you said. I did come back from the session, which went very well. Thanks. But yeah, as Carlo mentioned, we're actively engaged with most of the manufacturers currently restricting on ESP, along with many other manufacturers. So every manufacturer is assessing their 340B strategy. So one thing we take very seriously is we don't want any additional manufacturers adding restrictions on ESP or through other channels, right? And we've had good success there. And for the ones that are restricting, what they're telling us is that it's kind of a chicken and egg situation, right? So they're saying, hey, if you bring the CEs into the platform and you have enough penetration there, we as manufacturers are very interested in pilots to prove it out. And if those pilots prove out, then things get more serious about kind of what we do with what's happening in today's market. And I think to also want to say is, as the contract pharmacy protections continue to gain hold at the state level, and some of these rebate credit models kind of enter like long litigation cycles, who knows what will happen with those? I think we're very optimistic that manufacturers are shifting their mindset towards looking at solutions like the clearinghouse. So sorry to interrupt you there, Carlo, but I thought I'd just add that.
No, great clarity, Tim. And as I said, Tim heads up our manufacturer strategy, so he has more details. So thanks for sharing them, Tim.
I also say that Bryant's words resonated with me. I think it's bringing back and restoring trust. I think both sides have a role to play in that, for sure.
Yes, for sure. Sophie, any additional questions?
Oh yeah, we have a bunch.
Okay, great.
Has anyone received benefit from this model, or are we prospectively providing our data?
Well, I think, sorry, Carlo.
No, go ahead. Yeah, please.
I think the speakers on today's session kind of articulated some of the benefits that they're going to see from the clearinghouse at a local level. But my answer just 5 seconds ago, I think still holds true, right? We'll see those pilots take shape, and we'll see those successes start to come through as more CEs sign up. But I'll also say that there are other benefits, operational benefits to the platform that we're seeing as well. So as we're onboarding more and more CEs, for example, we're able to help them if they're not currently auditing 100% of their claims, like David from CVHS, we can help them audit 100% of their claims through the clearinghouse. So it's a big benefit from an operational perspective for a nominal cost. And the second benefit we're seeing from an operational perspective is a single pane of glass, we like to say. So if you have 2, 3, 4 TPAs and you're not kind of bring them into a single space to kind of assess your 340B program, we're giving you that capability via the clearinghouse. So there are some side benefits as well. Sorry, Carlo, if I jump in there.
No, that's great. Thanks, Tim. And Tim heads up our implementation teams as well. So he's hearing this with literally boots on the ground. I would share that to just echo Tim's point about the operational benefit. I've had at least a half dozen covered entities sitting in our demo, and the 340B team, whether it's the analyst, the manager, the kind of the boots on the ground folks as well, share that the one pane of glass, the audit function, was very valuable for them and a real time saver. And again, as Bryant mentioned, he's going to write into his policies and procedures the use of the clearinghouse as a checkbox in his P&P. So we know that's strong as well, that there's adoption at that level, which is a time saver. So again, but that is one right now that I think jumps out at everybody as a benefit. So yeah, another good question.
Okay, I'm moving into the Q&A chat where we have a lot of questions that we're going to run out of time for, but we will again send out a document after with answers to everything that we couldn't address today. Is RxParadigm for FQHCs or all 340B covered entities?
All covered entities. All covered entities. We've got Ryan Whites that are looking right now at our contract and coming on board. Hospitals and hospital systems. So we've kind of working with associations to bring, as you've seen today, this solution as a member benefit from time to time to their members. Others are signing up, and I call them ruggedly individual thinkers who are just signing up as well, as Bryant did. And he saw the solution as viable for his world. So critical access hospitals, dish hospitals, Ryan Whites, anyone who is 340B eligible, it would be is a great fit for the clearinghouse.
Okay. What is the timing of the process? How quickly will you receive 340B scripts from the CE or TPA? Once the CE and manufacturer sets of data are received, how quickly are the 340B scripts identified? PBMs have quick payment terms and the invoices are monthly.
Yeah.
Go ahead, Tim. I was just going to say just real quick, and I'll throw it over to Tim. The implementation period is about 4 weeks from our side. Really getting your TPAs motivated to share data to us would be kind of a nudging point that we would always encourage CEs to do. Tim, I'll let you take it from here and talk about the second half of that question.
Yeah, sure. Yeah, so current cycle that we collect the data from the CEs is bi-weekly. So every 2 weeks. So whether it's a monthly rebating process or quarterly rebating process for Medicaid or for the PBMs, we've had good success making those timings. And if the PBM does miss a cycle because the claim came in the end of the month, right, when they had to pay, they have the ability to go back and check and double check that work at a later date.
Sophie, we might have time for one more. It's 1:59. We might have time for one more.
Okay, I think Bryant has raised his hand.
Okay.
Yeah, I was just going to comment quickly. Am I on?
Yes, you are.
Yeah.
We can hear you.
Yeah. I was just going to comment quickly to a couple of those last questions that are kind of molded together. So the process, I think it's important to know that the process to getting set up, as Carlos said, it's about a 4-week process. It's really simple for the CE. Yes, it's for all CE types. The process is very easy because, you know, your TPA has the data. So essentially, it's a number of fields, and I don't want to say that this is simplistic, but essentially, right, they're working with an algorithm. So for our part, we're simply providing access to the TPA, having the TPA provide the appropriate fields. And once those fields are linked, then they're able to pull that data. So really, for if you're concerned about time, or, you know, because time is money, there's not a lot of time on the CE's part to do what they need to do to give RxParadigm the information they need. So I just wanted to make sure that that was out there, and understood that it's not a real complex process to get the data that they need.
Well, thanks, Bryant. And that might be the best way to wrap this up. So we thank you, Marty, Elena, and David for joining. Yogesh, thank you as well. And thank everybody for being here. And again, have a great day. And hopefully we'll see or talk to everybody soon.
Thanks, everyone.
Take care, everybody.